a breach in the intimal continuity, and the severity is expressed based on the axial, circumferential, and the longitudinal extent of the vessel wall injury. So this is the typical appearance of a dissection. Intramural hematoma is lesion of blood in the medial space with the displacement of the interelastic lamina compromising the lumen. Hematomas usually occur following balloon dilatation or stent implantation. So this is a typical example of intramural hematoma. Should have luminal compromise. You can see the split of media and the blood in the medial space. Extravascular hematoma is nothing but blood in the perivascular space. And the malapposition is lack of contact between the stenosis and the vessel wall with the blood speckles in between, or the Doppler flow if you have a chromoflow facility in your system. And the tissue prolapse is nothing but prolapse of clot components or thrombus in between the stenosis into the intrastent part. You can just see this is a typical appearance of your tissue prolapse. And muscle bridge is the artery coursing through the myocardium. You can see that the dark band of muscle which covers the artery and that exhibits systolic compression. So this is the typical appearance of your intramural vessels. And the coronary aneurysm, defined in the same way as coronary angiography, it is lumen size at least 1.5 times the reference. True aneurysm, as all three layers, true aneurysm is associated with the defect in the vessel wall. Lastly, remodeling. Remodeling is nothing but change in the vessel size at the lesion site. It is larger in case of positive remodeling and smaller than the reference in case of negative remodeling. Thank you.
The fellowship course you can ask, because nowadays IVUS is done even in peripheries also, which is a common issue, which we found. This is a common thing which you have to ask the questions which we are encountering in day-to-day practice.
So maybe I'll ask one question of Dr. Vijay Kumar to start. Given that this is sort of an early users course, what are the most important things, like this, let's say the most important features of an IVUS image that one should be totally aware of at the beginning of their usage? And, you know, what are the limitations of the various imaging technologies such that you might choose one over the other?
Yeah, I think it is the most important thing is optimal image acquisition. What the matter first. So it is choose the correct patient. To start with simple patients where you have type A lesions, highly unlikely you're not going to make mistakes. And keep doing them slowly. You can just go into a bit complex lesions like left mind, CTOs. So like that, you just go step by step. And you know all your basic image interpretation very well. Go through repeatedly. It's not like OCT. So it takes little more practice to learn about it, to identify, differentiate between normal and abnormal. Many times it is difficult to differentiate between different type of blocks with IVUS. To start with the simple lesions and keep learning, keep doing, so improve yourself. And optimal image acquisition is again very, very important. Suppose if you're using a mechanical system, preparing the catheter optimally and getting a good type of images, then your procedure makes a big difference.
Thank you. Dr. Nishit, because nowadays G catheters are more commonly used as a cost-effective strategy. What are the common type of artifacts you encounter with the G catheters, IVUS catheters, especially Indian setting?
So as I told you, that most common is the poor preparation of the catheter, because most of the time we use these OX catheters and to try to contain the cost. But you have to, but that is also very important. If you start charging the full amount of the IVUS catheter, the patient will not. That is actually the reason why many cath labs cannot start their imaging program, because the cost becomes so prohibitive. So that's what you have to actually, this is a reality which we have to do in India just to keep our imaging program going, but you have to reuse them. But what I have instructed to my fellows is that after having used that catheter, prepare them yourselves. Put them into that package yourself after flushing it. Don't give it to technicians. Because if you have kinked that, if you have mishandled it, then the fiber optics are broken, the transducer elements are broken, and you will not. So, and that way I have actually increased the reusability scale up to 4 to 5 times. So this is very, very important. Another thing which I want to convey to the newer fellows is because I started my journey of imaging with OCT, and when I moved to IVUS, I had a lot of difficulty in image interpretation. OCT is crystal clear with 10 microns versus 100 microns or 50 microns of HD IVUS. So always try to repeatedly see your images. Once you go back home, you take the DICOM images with you and try to repeatedly see. Every time you will find something new, that which you had mistaken. In the cath lab, you would miss lot of things. So Gary Mins also said at least see the scroll at least 3 times before coming to judgment. And the more you see, more you will learn. All these artifacts, whether this is an artifact, and correlate with the angiogram simultaneously. Unfortunately, IVUS does not have a co-registration, but what I do is play the cine film simultaneously and then correlate them together, landmarking with the branches. Thank you.